February is celebrated as Black History Month in Canada. This year, a unique discussion took place at the McLaren Art Centre in Barrie, organized by Making Change to address racism and build safer, more inclusive healthcare environments. The panel, called The Hidden Cost of Care, Racism and Inclusion in Healthcare Workplaces, was rooted in the experiences of LaChapelle, program director at Making Change. She shared the panel group from decades of healthcare experience across her team and board and from urgent need to support workplaces that are becoming more diverse but are not always prepared to ensure safety, respect, and inclusion for all staff.
To create that safe space for everybody in the workplace. And so that's where the idea for this came from. We applied for a grant from FFBC, the Foundation for Black Communities. They supported this idea of creating workshops that we can bring into healthcare institutions. And then from that came the idea of a panel event during Black History Month, because we do find in February, everybody is more open to conversations about issues around Black race and Black culture. And so it all just kind of came together. We've got a wonderful relationship with McLaren Art Centre. This was the perfect venue to be here. Our workshops are applicable to all kinds of healthcare institutions, and whether your healthcare institution has a higher racialized percentage or maybe your healthcare institution is mostly all white staff. Our workshops are about building an inclusive space. So it doesn't even matter if you're Black or a different racialized background. It's about bringing people together so that they can work in harmony. Because when staff feel in a positive workplace, then the health care for the residents that live in the nursing home or the retirement home, or the clients that come into a hospital and doctor's office, they receive better care. So it's a domino effect in a positive way when everything is all in place.
In the discussion, panelist Dr. Claudine Cousins, CEO of Empower Simcoe.
In regards to Simcoe County, 12.4% of the population identified as belonging to a racialized group. That was in 2021, which is almost double 2016, which was 7.2. So think about that, and then think about the systems that impacts. Those systems are like the Titanic. How hard is it to shift systems? How hard was it to shift the Titanic? So even though the makeup of our Simcoe County has shifted quickly, those systems are still the same as they were back in 2016. So as a result, our racialized staff are still feeling the barriers of trying to access or get through those systems. So we have racialized staff who are exposed to things like people they're supporting, or clients who are saying, I don't want a Black person providing support to me. I don't want this person touching me.
Dr. Michelle Kwai, Associate Medical Officer of Health at Simcoe Muskoka District Health Team.
It's called the minority tax. So it's really all the extra work that comes with looking different from how everyone else looks and being called on to do a lot of extra volunteer work to advance, certain EDI work. And so that can be really taxing. Some of the findings that came out in that study was looking at how a lot of the racism that racialized medical laboratory technologists face was actually from patients, but also from colleagues.
And Debbie Opoku-Mulder, registered psychotherapist and mental health advocate.
I promised I wasn't going to call up my husband, but you guys don't know him, so you won't tell him. But he says, he's a white male, and he says, there's such thing as Black fatigue. People are just tired of talking about EDI and all the things that come along with it, and they don't want to hear it anymore. So when people get tired, they get angry, and so they don't want to hear about it anymore. Can you imagine experiencing it every day and how tired you are of experiencing it every day? Right. EDI offices this is why EDI offices aren't not less important, but they're more essential.
Drew on different professional roles and lived experiences to address racism and inclusion in healthcare. Following is our coverage.
So myself as program director, I like to look at programs that I have a passion for, and I'm 20 years in healthcare. And one of our panelists, Debbie Apoku-Mulder, she's part of our team. She's from healthcare. Two of our board members are from healthcare. And so collectively, we thought, let's make a move into the direction of healthcare. There's a lot of diversity changes that have been happening, and when you work on the front line, you're seeing those changes, and you're seeing some of the negative effects that are happening when a workplace becomes more diverse and it isn't set up to create that safe space for everybody in the workplace. And so that's where the idea for this came from. We applied for a grant from FFBC, the Foundation for Black Communities. They supported this idea of creating workshops that we can bring into healthcare institutions. And then from that came the idea of a panel event during Black History Month, because we do find in February, everybody is more open to conversations about issues around Black race and Black culture. And so it all just kind of came together. We've got a wonderful relationship with McLaren Art Centre. This was the perfect venue to be here. And we selected Dr. Claudine Cousins, Debbie Apoku-Mulder, and Dr. Michelle Quay to be the panelists. They did an amazing job. They just come from such different backgrounds that their voices with the questions that they were being asked were unique and from a lived experience. Our workshops are applicable to all kinds of healthcare institutions, and whether your healthcare institution has a higher racialized percentage or maybe your healthcare institution is mostly all white staff, our workshops are about building an inclusive space. So it doesn't even matter if you're Black or a different racialized background. It's about bringing people together so that they can work in harmony, because when staff feel in a positive workplace, then the health care for the residents that live in the nursing home or the retirement home, or the clients that come into a hospital and doctor's office, they receive better care. So it's a domino effect in a positive way when everything is all in place. There is a common thread that we are all experiencing as racialized community members. And when you fix the system for one racialized group, you're actually fixing it for everybody. And for all of us at Making Change, we're about coming together to make change. And so that is going to be our South Asian brothers and sisters, our Indigenous brothers and sisters, all coming together, supporting each other.
Okay, so let's talk about this first question. When we talk about racism in healthcare, what does that actually look like, particularly here in Simcoe County? Because it's going to look differently depending on where you are. So let's focus on what the issues are here in Simcoe County. So Debbie, I want to start with you actually. From a community and mental health lens, how does racism in healthcare show up in the lived experience of clients and patients and families?
Yeah, that's a great question, Laura. Thank you. So when I talk about and when I think about community and mental health lens and how racism shows up, it's not necessarily isolated events, but it's more about patterns that happen over time. So let me give you an example. Say, as a Black woman, you are feeling pain, and you are in excruciating pain, and you go to see a physician. Or if you are having some mental health issues and you go and see a therapist and you try and describe how you're feeling. You know, this is what's going on for me. And imagine your pain and your symptoms are judged, are misinterpreted, are dismissed, are, oh, you know what, you're okay. You're okay. Everything is fine, right? There's nothing really wrong with you. And imagine that happens to you every single time you go to see a health professional. What are you going to do? Are you going to continue to go out and see a health professional? Probably not. Probably not. And this is a consistent thing that happens in the community. And, you know, I'm a psychotherapist, and I see this constantly happening, where people are feeling those feelings of depression. Anxiety, I don't want to go to work today. Something is going on. Something is wrong. And they're judged. There's stereotypes of, oh, well, you know, you're doing this, and that's why that's happening. They're looked at differently. They're not taken seriously. That is what's happening. And I can tell you, over time, these experiences create not just I don't want to go and see a physician, I don't want to go and see a therapist, but I don't trust my healthcare system. They lose trust. They decide that there is nobody here to take care of me. You know, we have free health care, and that free health care is not taking care of me. It's not taking me seriously. So that means delayed, follow-ups, or not going to follow-ups at all. That is, having your own idea of what physicians do or what they can do to help you. And then those feelings of depression and anxiety and sadness come about because you are in pain. You're trying to manage that pain, and nobody is helping you with that pain. That is the reality, and that is what racism looks like in our society, unfortunately.
Well said. That really ties into that idea of the hidden cost of healthcare.
Sure.
When you are not able to activate that free healthcare in the same way that everybody else does.
Yeah.
So Claudine, from a workplace and leadership perspective, what does racism in healthcare look like for racialized staff?
So I'm going to start with some statistics because I think that's always good in terms of grounding us. So in 2021, Statistics Canada says in regards to Simcoe County, 12.4% of the population identified as belonging to a racialized group. That was in 2021, which is almost double 2016, which was 7.2. So think about that, and then think about the systems that impacts. Recruitment, leadership, you think about governance and operations. Those systems are like the Titanic. How hard is it to shift systems? How hard was it to shift the Titanic? So even though the makeup of our Simcoe County has shifted quickly, those systems are still the same as they were back in 2016. So as a result, our racialized staff are still feeling the barriers of trying to access or get through those systems. So we have racialized staff who are exposed to things like people they're supporting or clients who are saying, I don't want a black person providing support to me. I don't want this person touching me. I don't want this person isn't competent enough, who doesn't have the skills to treat me. I'm not saying this because somebody's told me, I've heard this myself. This is something that is a truth that's happened not only in my sector, in developmental services, it's happened in the health system. This is something that is a truth. So when you have staff who are now hearing this, and then they bring it back to their supervisors, they're told, you misheard, you're overreacting, come on, you're taking this too seriously, right? So the barriers are there within the system they're structural, right? So these are things that are happening at not only the front of the system, recruitment coming in, but even in the operations of the system, in the governance of the system, so the leaders who are leading, and in the day-to-day services that are happening. So when that happens, imagine, not only do you have to do your job, stress, right? Because it's busy, right? You're working 12-hour shifts. People are coming in and out, in and out. And now on top of that, you're exposed to individuals who are casting your competence into question, who are saying just because you look a certain way, you're not good enough to do the job that you've trained for. So your mental wellness is now impacted. You're now getting depressed. You don't want to come to work. You don't want to speak up. You don't want to do anything. You don't want to contribute. You don't want. This is what's happening. So this is the impact that, more and more. Now you close off, your environment now becomes much more narrow to you. So this is, the result of what we're talking about.
For me, having done 20 years in healthcare, I can write a book on the things that I've heard as a worker. And it really is tough, and 20 years of that, it weighs on you. You know, those layers keep coming. So for you, Michelle, from a public health perspective, how does racism show up structurally in health delivery?
Thanks, Laura. So I'd say when we talk about racism in health delivery from a public health lens, we're really thinking about the structural determinants of health. So these are the conditions that shape a person's well-being, where they live, where they work, where they play. And so for Black communities in Canada, there's many different structural determinants. So it includes things like income, employment, housing, and we know that ongoing exposure to racism is a structural determinant of health. And this influences health outcomes. And it can shape the rates of chronic disease. It shapes different maternal and child health outcomes. It shapes people's comfort going to healthcare providers for delivery, like you had mentioned, Debbie. And so it's really not about personal choices. It's the result of the systems that exist within our health system. And so I think that it really stresses the importance of the upstream approach. So we like to think about an upstream approach in public health. So rather than thinking about, downstream when a person is sick, what can we do way before that to try and prevent people from becoming sick? And that goes down to addressing those structural determinants of health. And we can't treat our way out of those health inequities because they're produced by the social and those structural conditions. So we really need to address those determinants that drive the inequities and need to partner with those communities and build systems that are responsive, that are culturally safe, and that are reflective of the people that they serve.
It's really interesting how all three of you bring that different perspective, and you really see the whole impact, and it's real for frontline workers. And it's an important message for those that are going to be starting in frontline work. So let's move to question number 2. Claudine, what barriers do racialized healthcare workers face in recruitment, retention, and advancement, and just general daily workplace safety?
So, racialized staff are increasingly represented in frontline. The words you said in terms of frontline is really stark for me because I think about what I see across most organizations. If you were to do a cross-section of organizations and slice it down this way, and you look at it as a segment, you'll see at the front, you'll see racialized staff stacked at the front. And then if you go up the organization, you'll see less and less and less and less and less and less of the racialized staff leading up to the top of the organization, right? You'll see the CEO, and more than likely, 99% person is white. And going down, you'll see racialized staff stacked at the front, with the belief that that's as far as they can go. That is the best they can do. That is the most they can achieve. That is the best they can ever aspire to. And we see that, right? So they continue to face significant barriers to psychological safety, professional growth, and having their voices meaningfully heard within organizations. And it's something that is seen across most organizations. And when we talk about psychological safety, what we're talking about is individuals' ability to speak truth to power without being, feeling retribution from those who either work alongside you, who don't look like you, or those who work above you, who supervise you, right? So if you're not able to speak your truth, then it's not a safe space. And when you are racialized staff, you need to be able to say when something is not right. And if you don't feel you can do that, then it's not psychologically safe. So, despite being competent as anyone else, there's not the ability to speak up, so you sit on it and you suffer in silence. When opportunities do arise, what normally happens is it bypasses you. It goes to the next person who doesn't look like you, or when it does come to you, it's because, there's an EDI position that we might give you. We'll just, listen, don't laugh. Let's give it to the EDI. Oh, We'll just do that because then we can tick the box that says we have done EDI. Let's tick the box and let's put it out there so that we on the outside look like we are doing something on the inside. So because you are Black, brown, Indigenous, let's put it out there. Let's give it to you and you do it. I'm speaking truth, right? It's a safe space, so speaking truth, that's what we do. Let's give it to that, and the jobs that will give you, it's like a clinical position where you'll have some authority, a leadership position where you can make decisions around policy. No, that's not for you. That's not for you. This is for you. So that's what normally happens. Organizations in Simcoe County, I can count the organizations in Simcoe County that has a leader that looks like me. I challenge any one of you to say different. They don't look like me, right? So those organizations have command and control hierarchies. So when I have someone who looks like me to be able to speak up, I'm not going to speak up because I'm afraid for my job. I'm afraid if I speak up, somebody's going to say, oh, Claudine's a troublemaker. Claudine is talking too much. Claudine is not a team player. Claudine is a this, is a that, is a this, is a that, talks to, out the door. There's a reason this happens, right? So racialized staff usually encounter those barriers that proposes that, when they have good ideas around improving patient care, improving operations, improving how we do things, nobody listens. No one wants to listen, or you don't get the opportunity to speak up. Ideas are dismissed, they're overlooked. So these challenges are compounded, their managers just bypasses them. So when we see things like this, other co-workers are listened to, then we're not listened to, then this causes all these issues that compounds, and then racialized staff they're marginalized, right? So there have been instances where these patterns continue to happen, and when that happens, racialized staff shuts down. They shut down, and the workplace is no longer safe. They don't contribute, and they usually leave the organization. So that's what we see.
I actually want to speak a little bit about some of that statistics you were alluding to. So Stats Canada has established a prediction. By 2036, Ontario will be 49% racialized. That's a big number to kind of process, right now, to think in 10 years that will be the statistic in Ontario. So when we look at frontline staff, they are typically 10% higher of the ratio of staff in frontline positions. So if we're thinking 49% racialized, what does that mean percentage-wise for racialized staff? Racialized staff in frontline positions will make up 59%. So
food for thought.
Exactly. I know some of you are statistics nerds in the room. I am, so I wanted to share that as a statistic. Michelle, as a recent medical graduate, what challenges do Black medical students and racialized learners face within medical education and clinical training?
So there are definitely, a variety of issues or barriers that medical students like myself, when I was one, face. And I think it really applies across the spectrum of medical education and clinical training. So one of the big ones that comes to my mind, and I think you touched on this, Claudine, is really about representation. So it really comes down to when you don't see people who look like you in certain fields, for example, it's hard to picture yourself belonging, particularly if it comes to senior leadership roles within the medical system, or senior academic faculty positions, for example. So that would be one example. I think it also connects with mentorship. So mentorship is so key, in every field, but particularly in medicine. And it's so important to have mentors who understand your lived experience. But we know in medicine there isn't great representation, and so access to mentors is another challenge that medical students absolutely face, and that was a barrier that I faced as well. Something else I want to touch on is some gaps that have been seen in curriculum. So in academic studies, there have been talk about curriculum that don't include understanding or studying what dermatologic conditions look like on darker skin. So that's a significant gap that then impacts patients when they come to seek care if we haven't had that knowledge addressed. And even just in general, and I'd say there's been really good movement in this area, but addressing racism within the medical curriculum. And so that's one specific area that has been touched on and advocated for by a lot of different organizations within the province and Canada-wide as well. So just one shout out that I'll give is for the Black Medical Students Association of Canada, which has done a lot of really good work in this area. Something else I'll add on as well is something that you may or may have not heard of. It's called the minority tax. So it's really all the extra work that comes with looking different from how everyone else looks and being called on to do a lot of extra volunteer work to advance certain EDI work. And so that can be really taxing because you want to personally contribute, you want to make sure that you're making a difference for the medical community, but that comes at the expense of your time and perhaps your ability to contribute to your own personal career success. So I think those are a few examples. I also wanted to add that Claudine had actually shared with me an article specific to medical laboratory technologists, and it was looking at what racism looks like in that field, because we know that this isn't specific to medical school. This is all of healthcare and all healthcare fields. And what really struck me from that study was seeing that racism wasn't just interpersonal, it was really embedded in structures. So some of the findings that came out in that study was looking at how a lot of the racism that racialized medical laboratory technologists face was actually from patients, but also from colleagues. And that also, especially with the interpersonal interactions that people face, that impacted people's ability to advance in the field. And so, I think that really speaks to what Claudine has touched on as well. I'll leave it at that.
And Debbie, for you, just briefly, can you speak to the challenge many community members face in finding culturally safe healthcare and how to access culturally appropriate care that positively impacts health outcomes?
I'll say, unfortunately, there are significant challenges faced. And I guess I'll start off with the fact of availability, right? Is that available to us? And if I'm talking from the patient, from the client, from the family's point of view, yes, I would love to be able to go see a therapist that looks like me. I would love to see a physician that looks like me. Being a Black therapist, when I see a Black doctor, I'm like, whoa, can I get your information, right? Like, I want to be able to say, I know somebody who's Black, who's a doctor, but this is the reality, right? Representation does matter, but having that available to them is lacking. There's very, very few. I will say that it's improving from, say, 5 years ago.
Absolutely.
It is improving, but there's still the ratio to it. It's very, very few and far between. So that is the one thing. But the other challenge is just the barriers, right? Just the barriers of, I'm trying not to take this from a personal point of view, but I might have to. I might have to, this is a safe space, but just the fact of having to advocate for yourself constantly. Where you are not well, where you are sick, and if I don't have somebody that understands where I'm coming from, culturally, I'm facing those barriers and I'm having to advocate and then I'm having to say, you know what, I'll just figure it out on my own. And representation matters, but if we don't have the representation, then I challenge healthcare professionals to be culturally responsive, to look at things from a culturally responsive lens, trauma-informed lens, anti-racist lens, right? Yes, you may not be racialized, but can you educate yourself to understand those cultures? Educate yourself to understand the trauma that is faced every day for these individuals, historically and even presently. Okay? Can I challenge you to understand what an anti-racist lens looks like and how that is predominantly throughout our society, here in Simcoe County especially? I say this all the time, that, we've had a significant amount of snowfall this winter, and you can get on Facebook and see all the complaints around, the city of Barrie and trying to plow the snow, and it's still there, and somebody got online, anonymous of course, and said, stop complaining about the snow. It's the only white thing we have left. And so I had to, I don't know, because I laugh so that I don't cry. But this was just a few weeks ago, right? So this is absolutely what is still happening in our society. And so can you imagine those folks that need the health care, that need that support, that need to see a therapist, and this is what they're faced with. So I do challenge the fact that, we're not all racialized, we're very diverse, it's a wonderful, beautiful thing, but can we be trained in cultural lens, anti-racism, trauma-informed, understand what our community is facing and seeing, and be able to support them in their healthcare journey.
Thank you. I want to add, I know we talked about sort of things getting on a personal level. I do have to give a little shout out to my doctor. She is not racialized, but when I was diagnosed with high blood pressure, she thoughtfully decided, I'm going to look up medication that is more effective for Black women, because genetically it was a likely factor. It runs in that side of the family. And she thoughtfully did that. So you can get good care from a non-racialized medical professional, but they have to be taught, to be shown that you need to look at it cross-culturally when they're doing their care.
And compassion.
Yes. Thank you. Thank you, Chris.
Yes.
So in this work, we're constantly seeing racialized families delaying care because they don't feel understood, respected, and that delay often leads to worse healthcare outcomes. And this is a question I wanted definitely to touch on, is historical piece when it comes to trust in healthcare for racialized families and patients. So Claudine, can you help ground us in that historical context on the mistrust in healthcare?
Absolutely. So centuries of mistrust and mistreatment, including slavery. I did say slavery, people. Slavery. Colonial medical exploitation, forced experimentation, sterilization. I could go on. Lots and lots of mistreatment of Black Canadians has left a lasting distaste, right? If I could say that, in our mouths, right? So take, for example, the infamous Tuskegee syphilis study in 1972. So this is one that most people know about, most people have heard. It's an example of a mistreatment that goes beyond the pale, right? Goes beyond the pale and has contributed to this mistrust in our health system. The purpose of the study, and every time I read it, I just want to scrub it from my eyeballs, because I'm like, this can't be I do research, and the purpose of this research is something so heinous that it hurts my heart to even read it to you. It was to observe the effects of the disease when untreated, right? So give the disease to somebody and watch what happens without doing anything about it. And this was given to Black men, and they were watched up to the point of death to see what happens. There was no informed consent, which means they weren't asked whether they wanted this done. They didn't agree to it. And even though there was a cure, or there was medication that was developed, penicillin, at some point along the way, they were never given it, and they were just allowed to die. This happened. And why not? Black men, they were just tossed away. Why not, right? So this happened. And then what happened in 2019? What happened in 2019? COVID, our favorite friend, COVID. And then you want us to take vaccines, you say? I don't think so, right? So 2020, COVID vaccines come out, and then we are being asked to take vaccines. It may be 50 years almost, but the memory is still here. We still have memory of this event, and the mistrust goes deep. It goes really deep. So, asking a Black community, other racialized community, to take vaccine that's been developed, we don't know how you did it, we don't know who you did it on, and now you want us to come and take this, we're not taking it, right? It wasn't going to happen because people are still aware of what's happened. This mistrust in the system is there. It's not easy to get rid of this mistrust. So when we see that happening now, we're talking about Black people are normally being told they have great pain tolerance, they can stand certain things, and they're treated differently. So that's why they're used to test on, right? So I can tell you that I have examples from my own life where I have friends who have been feeling pain and they're told, I have one girlfriend who was in labor and the nurse said to her, "What are you crying about? Didn't you know when you were making the baby that you were going to feel pain when you had the baby?" And walked out of the room. Right? So these are the types of things that Black people endure from our healthcare system, right? So these are things that build mistrust in our system. So, when we're asked to then turn around and take medication or agree to certain things, it's really difficult. So the distrust is really deep within the system. So during COVID, the mistrust really built up within all of us. So I know within Simcoe County, I was asked, as well as a number of other Black community members, to work with the Simcoe-Muskoka District Health Unit to help them to get the youth to access the vaccines, to access care, to help with data, because they just couldn't get them to do it, right? So we know that the distrust is embedded in our system till today, and restoring that trust has been lost requires some intentional work. It requires all of us, because the system itself will not make it work. It'll take us along with them to make it work. So absolutely.
And when we think about that ratio again, it was the frontline staff that were first to receive the vaccine and who had the higher percentage ratio of, racialized staff, frontline workers. And so that's where that mistrust, why are they giving it all to us first? What is going on? And as a frontline worker, I remember that, because I was a frontline staff at the time COVID hit. So Michelle, let's talk to you a bit about that mistrust still playing out in public health systems and health delivery today. Why is it important to have trust between public health and the community?
Thanks, Laura. So I think, like Claudia illustrated, so even if our intent is to support and to protect communities with the legacy of discrimination, the messages can't always be received with trust. And I think we can all understand that based on what Claudia has described. And so that mistrust shows up as people delaying care, hesitating to ask questions even if they have them, or feeling unsure about whether the system sees them and respects them. And from a public health perspective, we know that this can then lead to widening of health gaps, because we know what the effective interventions are, but trust is a major issue. So I think trust is really foundational to public health, and it really comes down to relationships. So I appreciated you sharing the example from the COVID-19 pandemic, Claudia, because That is the most important thing. We can already have the data, in some cases. We might already have the evidence. We might already have the programs ready to go. But if communities don't feel safe engaging with us and building that trust, then the impact will always fall short. So I think we see trust grow if we show up consistently, if we are clear in our communications, and if we really aim to build those relationships, recognizing that legacy of racism that is very, very strong within our community.
So it'd be nice if trust alone could fix everything. Unfortunately, it will not. So let's switch to what meaningful change actually looks like. We need systems to back up our words, real policies, and procedures. So Debbie, we're clearly seeing a decline in an EDI focus, partly from the change we're seeing not just in the US, but also globally. In your work in EDI at Georgian College, describe the importance of having an EDI department, community groups, organizations, and institutions. Why do they need EDI?
All right, so we're not going to get political here. All right, so, all right. A little bit. But we are seeing a shift, right? We are seeing a shift. 2020 hits, and it's we need these things because this is very, very important right now. Like, we got to make sure that we have these equity offices and departments and groups because there's a lot going on in our world. And now we're seeing a shift, whether it is politically, whether it's culturally, whether, and this is I promise I wasn't going to call up my husband, but you guys don't know him, so you won't tell him. But he says, he's a white male, and he says, there's such thing as black fatigue, Debbie, right? Like you know that, right? I said, well, what does that even mean? What does that mean? It's just like, because people are just tired of talking about this. People are just tired of talking about EDI and all the things that come along with it, and they don't want to hear it anymore. So when people get tired, they get angry. And so they don't want to hear about it anymore. And so, yes, I get it, right? People are tired of hearing about inequities. People are tired about hearing about, yes, this person should be here because they're not here. Yes, they're all tired about it. But I'll paint another picture for you. Can you imagine experiencing it every day and how tired you are of experiencing it every day? Right? EDI offices this is why EDI offices are not less important, but they're more essential. Because when we get tired of hearing about it, it becomes less and less important, and it becomes a checkbox maybe. February, Black History Month, let's make sure we do something, and check, we did something, we did a book club, or maybe we did a talk, perfect, we did our part. And it becomes less and less essential, and we forget about it. We forget about the needs. We forget about the inequities that are happening all around us. We forget about those voices. I'm sorry. Thank you very much. Okay. Hope you got that all. We forget about those whose voices are marginalized and aren't heard. And they're essential because they keep those at the forefront. They're essential because they keep us accountable. They're essential because it ensures that we are including everyone. And everybody gets a place at the table. Because without them, we continue to care less and less. And those whose voices matter, because all our voices do, but those who essentially have been historically told that your voice doesn't matter, continue to hear that all the time. I see EDI offices as that anchor, right? That keep us stable, that stabilize the fact that this is important, this is still happening, and we need to ensure that this continues to be at the forefront. And we keep checking ourselves, not just checking a box, but checking ourselves to understand, have I ensured that everybody in this room has had a voice? Have I ensured those who aren't in this room have had a voice? Have I ensured that those who are not being seen are being seen and know that they belong? That is why it's very, very important that we keep these groups, these committees, these departments, so that we can keep ourselves accountable and understand that, yeah, this is still happening. Not just in the States, this is happening in our county, in our city, in our communities. I've gone to several schools, in the past couple of months, and I said, this happens in your school. And I'm telling this to these kids, and they're like, really? Yeah. The person beside you is probably experiencing this all the time, and you didn't even know it. It keeps us accountable and helps us to understand, because this continues to happen, and we need to be doing something about it every single day.
Thank you. Thank you. Well said. Claudine, from an organizational leadership perspective, why are strong equity-based policies essential as the blueprint for workplace culture? Remember in our earlier discussion a couple weeks ago, we talked about that blueprint, and it's so important, and I would love for you to talk to that when we're looking at accountability.
Sure. Well done. I think that meaningful inclusion means more than policies and diversity plans, right? So it is the foundation for workplace culture, and culture is the way we do things around here. That's how I define culture, and it's a reflection of everything that happens in the daily lives of people. True inclusion requires cultural shifts, right? So when we think about our policies, and we can't separate policies from the everyday work and from the culture that we have. So when we think about what we just heard from, from my colleague here, that the EDI office is the anchor, we got to think about it being more of the anchor than the rhetoric, right? More than the tick boxes that we hear sometimes, and that the reflection of what we see on the outside is more about, oh, it's Black History Month, we do our part and we go away. I think equity-based policies are more about how we treat employees, and how do we make sure that we recognize that our employees aren't monoliths. We are not all the same. Yes, 3 of us are Black, but we're not all the same. We're not all the same. And we have to recognize that employees, racialized or not racialized, because whether we like it or not, I lead an organization and I can't just take care of my Black staff. I have to take care of all my staff. When we talk about equity-based policies, it recognizes that the whole organization treats each staff as an individual. It treats my white staff as a white staff, my Black staff as a Black staff, it treats everybody as an individual. So if this staff needs something today, the other staff may need something different tomorrow. So equity-based policy says that it's flexible enough to shift and morph based on what my staff needs. And that's the type of policies that you need in order to be responsive to your organization, to build a culture that says everybody belongs, that says, I will take you as you show up today, I will take you as you are. I'm not going to take you as a group and create a policy that says everybody must fit into this policy regardless of who you are, because that's the colonial way, right? That's the way where we have a square peg that has to fit into a round hole, and it just doesn't work, right? Because we are all different. So equity-based policy means that we look at each person and we think about what they need, and we build that policy that recognizes that they're different each and every day. And if they're going to belong, then the policies need to move with them. They don't need to move with the policy.
I think if you look at equity-based policies, and this is a nod to my father who's a carpenter, but as the framework of your house, and EDI is not this little flower pot on a little table, it's part of that framework. Michelle, why is collecting race-based data essential to building equitable health systems, and how does that data drive meaningful policy change?
Thank you, Claudia, for your answer. I took some notes. It was very helpful.
We're learning together.
So for me, race-based data and socio-demographic data more broadly is really about visibility and it's about accountability. Because if we can't see where the inequities are, then we can't fix those inequities. So, I really think that foundation is important, especially for communities that are underrepresented or who haven't been well served by our health systems. And I think that the real value of this information is that it can help us to see where there's gaps so that we can address those gaps. And without the data, we rely on anecdotes, which are important, stories are important, or assumptions, and at the end of the day, we might not be able to design the most effective solutions. So I do think that race-based data is really important. But one point I want to make is that this data has to be collected and it has to be used in ways that are genuinely useful for the communities. And it has to be in accordance with what they've decided is useful for them. So it needs to be done with partnership. It needs to be informed by those communities. We can't just go in and collect data without a plan for how we're going to collect it, how it's going to be respectful and compassionate, and how we're going to use it. So that all needs to happen before that work is done. So that's my take-home point for that one. But I'd say that when we do lead and co-design with communities, then we can ultimately use that as a tool for empowerment. With that data, we can then work together to decide, okay, how do we want to address these inequities and address these gaps together?
I noticed, especially in the last year or two, we've had different institutions and organizations start to reach out to Black-led organizations, such as ourselves, to bring in that equity lens to look at their policies and procedures and see how does that need to change, how does it need to be edited so that it correctly accounts for everybody in that workplace. So I do appreciate more and more are starting to take on that task. It's so important, and we hope that continues. I know it's a service that Making Change provides. As someone working inside nonprofit systems, I've learned that values without policies remain intentions, and intentions without accountability don't change outcomes. If we want real lasting change, we have to break down what happens, what must happen next. If we do, we go from not just talking about it, but we go to making change. So this leads us to our last question, those little nuggets that everyone can kind of take away with them as well. And solutions, and how do we move forward from here? So the first question, I'm actually going to take it back to you, Michelle. Why is meaningful community engagement essential for public health strategies to succeed?
So I think it really comes back to the fact that if we do not design, programs and services that reflect the lived experiences of the people that we're serving, then we won't achieve the impact that we're hoping for. So it's essential. Communities know their needs best, including the barriers and including the potential solutions. And so we need to listen so that our work can become more effective. And I think it also ties back in with mistrust. If we are aiming to build relationship with communities, then that's going to help to build trust over time, the way that relationships do. This is especially important for Black communities where we have experienced historical harms. But when we collaborate, then relationships grow at the end of the day. And I think another piece that's important to mention here is that engagement can also bring forward strengths, because we know that communities have strengths. So we have cultural knowledge, we have leadership, we have networks of organizations, and we have resilience as well because of what we faced. And all of these things can be used to enhance the way that we provide service to communities. So at the end of the day, again, bringing it back to co-design, we should really be co-designing with the communities that are going to be effective, and that's going to make what we come up with more responsive and more sustainable.
Debbie, how do nonprofit organizations and community partnerships play a critical role in supporting mental health and trust building?
Well, I think they play a critical role because they operate where a trust already exists. So if you have been, constantly marginalized and there's been harm done to you in terms of the healthcare system, you're going to go, if you are going to go somewhere, you're going to go somewhere that you feel trusted. And it's not going to be a big, large institution. It's going to be probably a nonprofit organization, a community where it is smaller, but it also does understand the cultural awareness piece. and being able to support the community, because they support the community. So you're going to go to where you can find that trust. And that usually is a nonprofit organization. And why they play a critical piece is because sometimes they can operate as a bridge to these larger institutions to be able to say, let me help you and walk with you along this path and help to support you. And so that's why I think they're so important. They understand, and I come from the nonprofit background, and I absolutely love it. And you know the pay is not the best, but it's not even about that. It's about the heart. About the heart, right? It's about the heart, and we are in the business of supporting and helping those who need that help. And so nonprofit organizations do that exceptionally, and I wish our government understood that and to be able to support them better. But they offer this support that they're not getting out there in the larger institutions, and they're coming to us, and we're helping to bridge that gap and actually helping them to be able to advocate for themselves, eventually getting to that point to do that. So they play a very, very critical role in our community.
Thank you, they do. Claudine, what responsibility do healthcare leaders and executives have in dismantling systemic racism? I know, I left you with a big one. Give us a mic drop moment.
I love the question. I love the question. I might read the answer. I don't want to miss not one word.
Go ahead.
This is so important. My colleagues, I love you. What you've said, so important. But it starts at the top. What you've said, absolutely. But without the commitment to dismantle systemic racism from leaders at the top, from executives to first commit to the work, verbally to orate, to actually put it out into the world, to put it out there. Like, I don't want you whispering in the back. I don't want you talking to your friends in a corner. I don't want you writing it down on a piece of paper. I want you to send it out into the world. Tell everybody. I want you to talk about it. Leaders, executives must first commit to doing the work. Allocating, hear me, allocating necessary resources. This work don't come for free. Allocating necessary resources and effort required to do the work. This isn't a nice to do. It isn't a, do if you have the time to do. This is a must do, right? Because we always get caught up in the, it's off the corner of my desk. So I don't have the time, so it falls off the desk. So it never gets done. So the only way this is gonna get done if it's absolutely committed to. So healthcare leaders and executives are responsible for implementing culturally safe, trauma-informed practices to model the inclusive leadership that in their decisions and in their behavior. They're responsible for championing and modeling change at all levels. If your front line don't see it happening, they don't believe it's happening because their boss didn't say it's gonna happen. Their boss isn't doing it. So why would they believe it? If I don't do it at work, they don't believe it's happening. Oh, Claudine's not doing it. She's a CEO. She's not doing it, so it's not really happening. So you have to lead from the top. Co-designing, as we've heard, absolutely. Lived experiences, value what people have to say, what they bring to the table. You cannot we have a saying in our sector, you can't do it without us, right? Nothing about us without us. That is a fact. You can't tell me about myself. So if you want to know about me, you got to do it with me. And finally, we got to hold institutions and each other accountable. I'm not going to hold myself accountable as much as you're going to hold me accountable. So we have to do that. We need to have policies that result in action and care that is culturally responsive, equitable, and trusted. If that doesn't happen, we might as well just stop now. But it starts at the top.
Well said. It does start at the top. And Debbie, with all the different Black-led nonprofits that are here in Simcoe County, we are hearing from community We're here to support that work. Bring us to the table.
Yep.
Pay for a seat, we'll come to the table.
Pay for the seat.
It's not free.
No. As we come to the end of our panel here, I want to take a moment to reflect on the powerful conversation that we've shared here today. We've heard from Claudine about the experienced racialized staff in healthcare workplaces and how leadership and strong policies are important to creating equity. Debbie has reminded us of the real impacts racism has on mental health in our communities and the critical importance of culturally safe care. And Michelle, you've helped us see the systems perspective, how race-based data, policy, and community engagement can create meaningful change. These moments stay with you, and they remind us why this work matters. Racism in healthcare isn't just a statistic. It touches real people every day. I've been affected by it. All of you have been affected by it. This touches us every day. Today's discussion shows us that solutions are possible when healthcare leaders take accountability, when policy guide action, when nonprofits and community partners support culturally safe care, and when communities are truly engaged. Change happens when all these pieces come together. It isn't just one thing, it's all the pieces coming together. Now, I'd like to open up the floor for some questions. I know we've had a lot of really interesting information, and it might have inspired some questions. So it's a good opportunity to ask our amazing experts on their thoughts on challenges that you want to dive deeper into. And I do have a mic I can travel with as well. I will trust who wants to tackle a question. Does anyone have a question at all? Yes?
I can be loud enough.
Oh, yes, you are.
Aaron Lewis with Victoria Village Long-Term Care. With leadership, I welcome his thoughts or experiences with regards to board of directors. We talk about healthcare, we're largely governed by not-for-profit structures, volunteer board of directors. When you get into crisis situations, you usually see people parachuted in with experience in certain standing to be able to help address this. But how can a board of directors, through your thoughts and experiences, this be addressed truly at the top and the accountability?
Sure.
Yeah.
Thank you for the question. I'm proud to say, you know, at Empower Simcoe, I've been truly blessed to have an excellent, very supportive board. So when I say that it starts at the top, it actually starts at the top with my board. You know, the board is very supportive of everything that I do. When I was hired, I made sure they knew that I was a Black woman, you know, because my lens is different, and I wanted to make sure that they supported what my lens was. Anything that I did and brought forward to the organization, they also went through it. Every training, every strategy, every approach, they marched right along with me. So, you know, if you want to take on EDI or just being equitable based organization, then your board needs to be right there with you. And, you know, you take it to them and talk to them about the approach that you want to take. And if your board is really supportive of you, then they will either say yes or no. And, you know, if you need to be supported, I'm more than happy to come and support you in that regard, in helping to have conversations with your board to talk about how that works. But it does start at the top, and your board is the top. So
It's how you select those to be on the board as well, though, right?
it's, you know, I don't select my board based on wanting to, I don't want to stack my board, let's say. My board is chosen based on their competence. I wanted someone on my board who was good in communication. I wanted someone who was a lawyer. I wanted someone who was good in fundraising. So those are the things I was looking for. But their values needed to align with Empower Simcoe's values, and which included belonging.
Yeah.
So that's what I looked for from a values perspective. But their actual competence is based on those true tactical types of competence. Yeah.
That's a good question when you think about, that board of directors, because that's part of that team, that's part of that accountability piece.
Yeah.
And there is quite a few Black-led organizations here in Simcoe County that offer different education services. For us at Making Change, we have invested this last year, thank you to the grant funding from Foundation for Black Communities, to specifically create inclusive workplace workshops. We're here to provide that support, and it's incredible work that needs to be done. We have another question in the...
Just to that point, and I have been privileged to go in and provide training for making change in governance and in their strategic plan, but I've also brought in individuals from Black-led organizations into my organization to also provide training for my organization as well. So,
question in the back.
As a healthcare worker at that direct care level, a question that I find management brings up is about common language. When you have a mixture of races at your hands-on level, sometimes in the casual situations in the staff room, you have different languages being spoken, and it sometimes can create an animosity. And I was reading an article about recently that said, do you consider English the common language? Is there an expectation that everybody in a common environment speaks English? But then sometimes people are just comfortable talking together in their own language, but it can be misinterpreted. I'm just wondering, how can management address that?
wow, that's a friggin' great question.
Debbie? Claudine? Debbie, start us off.
Whoa. So, that's a fantastic question. Whoa. Our organization is a safe space. So, everyone shows up as they are. So we are not dictating whether you speak, English or French or whatever you need to speak, you speak. When we are together in a space, if we are collectively here having conversations with each other, we're going to speak a language all three of us understand. But if all of us are here together and there are groups separated within the space, there could be people sitting in the space who do speak different languages within the broader space. And there has never been within our organization that I have heard where there's a complaint that, we were in the lunchroom and there's 3 staff that was speaking, Hindi, and we think that's offensive because we couldn't understand. They could have been talking about us. What? No, we have never heard that. However, I'm going to put my ears to the ground now and see if I do hear anything like that. But it's a great question. Your turn.
Well, I think it's also
How does that affect? It does happen. I have seen it myself.
It does happen. And it probably
But I have staff,
isn't where managers will hear about it,
No.
right? It's probably the people, maybe frontline staff that are experiencing it, not thinking to bring it to management because what are you going to do? So you sit there and you internalize it, you experience it yourself, you keep showing up to work, but there is harm being done.
Yeah, because
at
you're
work
dwelling on it. You're sitting on it.
dwelling on it all the time. And I think, oh my goodness, this is it's a global issue too, right? When you think about Canada, and this is Canada, our first language is English and French, and then, we got the other languages coming in, and how diverse we promote Canada to be, and we're so wonderful, we're so great, we take in anybody,
But
and now
are we?
the conversation is
But are
not
we?
like that anymore.
But are we?
Right.
Yes.
That would make sense.
Yes, but you were referring to when Canada
Yes.
came
Formed.
together
Right,
under its
right,
current
right,
structure.
exactly,
Yes.
exactly. But this is why we have these conversations.
It's a
right?
great question.
It is a great question, and it does happen all the time. And yes, I'm glad you're going to put your ear to the ground, because these are people who are not showing up and
Yes.
saying this to you
Absolutely.
because of fear of
something.
something.
We have 46 different languages within our workplace. 46. because we just did a demographic survey. So can't imagine.
That's amazing.
Yes, 46 at Empower Simcoe.
Okay, another question from the audience. Janelle, do you need a microphone or you?
I think I should be able to be heard.
Yes, I thought so. That's why I didn't budge.
First of all, thank you, Making Change, for this. And I would love to have coffee with these women. So, so I'm wondering if there could be such a thing as black coffee.
There is, and we will be having one in the spring.
All right, good stuff. So brilliant. Thank you so much for sharing that and for speaking into our experiences. One of the things you talked about was the importance of representation. And I wonder if you could comment on my thoughts on that. Being that representation is kind of like the first tier. Because what happens is if we get people, I'm thinking about the impact that you talked about around colonialism and the internalization of trauma and all those kinds of things. So sometimes in our black bodies or in our racialized bodies of whatever type, we are so indoctrinated, injured, beat down, that just being there, we still are not empowered to be ourselves in those spaces of leadership or of action. And so I just would love to hear your thoughts on how to move beyond just mere representation to real agency and voice in these organizations.
Do you want to go?
I can start. I'll give my thoughts. Yeah, I think that's such a good point. And I don't know, I really come back to what Claudine is saying. It really is about leadership. I think that if we are aiming to increase representation, we need to make sure that those spaces are safe. We need to make sure that we can feel comfortable in those spaces. So that is, it's such a hard part. I think in one way representation is the first tier, but in another way, you almost need to do that groundwork as an organization first. Make sure that you are set up as an organization to support increasing representation with the ultimate goal, of course, of making sure that the community feels safe with the care that they're receiving.
I think it is important for healthcare workplaces to get on the hamster wheel of what's happening in reality. As we were talking about earlier, in 10 years, our demographic is going to look very different. And is your workplace ready for that change? You know, it's best to get started on that journey now and not wait. You know, get those policies and procedures that have the equity lens already started right now. Start today, start tomorrow, because it's going to be a dramatic shift.
Yes, Roxanne. Another voice that doesn't need a microphone.
I hope so. Is everybody hearing me?
Oh, yeah.
Okay. All right, so I just want to make a contribution, having worked in healthcare for upwards of 2 years, just to contribute to some of the, the barriers and the things that, Black folk experience working in organizations like in the healthcare system. Some of the things that I struggled with is, number one, over-policing of regular staff like myself. So you talk about people looking at you, we're on the same level, we're all PSW. But if I'm supposed to go on lunch, I have another staff who's coming over to, dictate when I go to lunch. This is a staff like myself, not a supervisor, right? I had cases where I would go to lunch in the lunchroom, and I would have a whole interview about my hair, right? Some of those are the things. So many. I have experiences where I go to look after a client, and they say, "Don't touch me, you're Black." And I say, wow, I didn't know I was Black. Thank you for telling me, right? So those are some of the things that we experience. And I want to know, you talk about starting at the top, but even as a supervisor, I was attacked by regular, staff like myself, and my supervisor didn't do anything to protect me, right? By the time I turned around to respond, I was told, oh, you're attacking, you're angry. And I'm like, but why wouldn't I be angry? I was attacked. You did not see the other person attack me, but you will see when I stand up to defend myself. Now, does leadership train, other staff with, number one, the over-policing of black bodies in spaces like those? That's my question.
This feels like a Claudine question.
Is it training?
Staffing?
It's not training,
Yeah.
it's setting expectations, and it's more than training. I mean, it's the environment, it's a culture that's been set within your workplace, right? So it appears to me that the culture or the environment that's been set has created a two-tiered type of environment. Your supervisor or your colleagues been allowed to do what they're doing, right? So within a workplace, a colleague is a colleague. They are not a supervisor. So obviously it's either policies are not clear about who's accountable for what and who's responsible for what, and that colleague feels that they have a supervisory responsibility over you, and you now don't have a voice to say, you're not a supervisor, I am not responsible for X, Y, and Z when it comes to you. So your workplace, when I talk about leadership, for myself, when I talk to my supervisors, my directors, my VPs, I'm clear as to here's your role and responsibility. Here's your role and responsibility. And I've had a frontline staff come to me and say, same thing, this has happened to me. I went to my supervisor and they said, I overreacted. They came to me because I'm a black person. They don't have to come to me because there's someone they can go above that person. I sent them back to that manager because I want to see if the process that I've set up in the organization is working. If it doesn't work, I'm going to step in, right? But I don't step in right away because I've set up a process. So when they go back, my expectation is that that manager goes to that supervisor and say, why are you not responding to the staff's complaint? Your response is to go to that other staff and say, your job is not to supervise this person. Don't let it happen again. And if it happens again, it's a performance issue. That is the expectation from me. If it happens again, then if that manager doesn't do something, then that's a performance issue for them. So that is it's an environmental thing that's been set up within your environment, right? So that's what that is. So that's why I'd say it starts at the top. It starts with your management or your leadership, setting clear expectations through policies and then behaviors and then holding people accountable. That's what that is. Because absolutely it's happened in the workplace. It's happened when I started there, and I stamped that out right away because that is not acceptable.
Thank you.
I just wanted to finish it. So what I see, and I think you've mentioned it before, is that, people are afraid to speak out.
Okay.
Right? So there are times when you will just stay there, you just soak it up, you say, I can handle it, and, it ultimately leads you to just leave the job. Because the psychological safety is gone, there's nobody protecting you and all of that, right? So those are some of the challenges that I see. The fear, because you want to keep your job, and this is a person who's higher than me, and if I report, then, and sometimes supervisors and managers are friends and buddies.
Sure, yes.
Right?
Yes.
And when you think it's a protection, then you get kicked to the curb. So those are
So within your organization, if it's a psychological safety for you, you need to find someone within your organization that you feel safe talking to in order to deal with that. Because if you sit with that, you're either going to leave that organization or you're going to burn out or something, mental wellness is going to happen. You need to find it may not be your direct supervisor, but you need to find someone to do your advocacy on your behalf because you don't feel safe.
I already did the job.
See? There you go.
Okay, we have a question in the back.
Yes, my name is Constantine. This question is for the clinician on the panel. I'm going to use your story a little bit because you guys identified that systemic bias, of course, is one of the biggest issues that's causing a lot of these problems, right? So, and you talked about the medication that your doctor identified. So, as a clinician, as you go through your clinical pathways, would demographic information, would social determinants of health, aligned with health outcomes, help you make better decisions when it comes to your care plans?
So just to make sure I'm understanding right, you're asking if as part of the training pathway, if when we learn about that, whether that's useful in clinical practice?
Because you're a practicing doctor, right? So the patient comes in, you're sitting there, and they're giving you symptoms. You put in your clinical pathway, there's a bunch of recommendations that are this is where you're supposed to go. You have a patient who's black, and so they may have special demographics that that may align with your care outcomes you want to achieve. There may be social determinants of health, which you mentioned. Would that information presented to you on your dashboard for your clinical pathways help you? Would it be valuable to you to have that to make better decisions about her care? Because otherwise you have to go outside of the truth, right? And say, I'm looking at her, I know there's something different than what I'm getting from your clinical pathway or your standard of care.
Okay, so asking more about incorporating that information into clinical pathways and whether that is useful.
Exactly. Because when you talk about systemic discrimination, it kind of bleeds down, right? So if it would help you to address, to mediate that systemic discrimination, would that information help you as part of your work?
Okay, thank you for that question. Really interesting. So, I mean, I would definitely say that overall, when I'm seeing a patient, I don't practice clinical medicine as my main gig, it's public health, but in clinical interactions, you absolutely want to consider every aspect of the person in front of you. And the social determinants of health are an important aspect of that. And so having practiced in different clinical settings, at times we incorporate some of that information into our clinical information system. So when I'm seeing a patient in front of me, I might understand some different aspects about their background that is going to help impact me in the decisions I make. So I might understand that access to medications for this client is going to be an issue. Can I refer them to some of our different allied support services to help them through this process? Or I might recognize some risk factors that they have based on those social determinants of health. And so that might prompt me to ask them questions about things that might not have come up otherwise because I've understand a bit more about their background. At the end of the day, I think if that information is being included, I think the most important thing is that the patient in front of me knows that that information is part of their clinical record and that they're okay with that and that they're comfortable with that being used to inform clinical decision making. But absolutely, I think that that's really important. I think that that's really helpful, and we really need to consider all aspects of a person in terms of where they work, where they live, where they play, in addition to all of that other medical information.
That's a great question. Yes. So we're just coming to the end of our time. I know that our panelists will be here for a little bit after, but I see one question here, and I'm so excited you brought some students that are in healthcare.
Oh,
Do you need a microphone in your lap?
Oh, I don't know.
I know. All these people standing up, I already know you.
I love it. Actually, it is just on behalf of the students, because I have some students here that are considering the healthcare sector pathway, a secondary, and then applying to post-secondary. Next year we have, what would be like some words of wisdom or a great food for thought for them as they consider which school or pathways in terms of embedding everything that we're talking about today to support
You didn't hear what she said, did you? Oh yeah, don't don't worry, it's okay. No. You did great, not you.
Anybody want to answer? Words of wisdom.
Yeah. First of all, I think that it is great, and I don't know if this is your first kind of understanding around this piece of the healthcare system, but if it is, I'm thankful that you're here today, and this is what you're hearing. I want to say that it is not all terrible, but there is some really, really great stuff about this, but I want to say that those who are trained in culturally safe care, who are trained in anti-racism, informed trauma, all of that stuff, who make it their duty to be trained in this on top of the medical stuff. I want you in the system.
Yeah.
I want you to be part of this healthcare system. And yes, there is a lot to learn in the medical system, so great for you, that's wonderful. But make sure that this is part of it as well. And make sure that this is at the forefront, because we want to ensure that there are people who are, everybody is healthy. This is why you're getting into it. You care about people's health. You want to ensure that this is not just a short-term thing, this is a long-term. And so when we can provide that appropriate care, we can ensure that we have a healthy community, healthy people in this country, in this province, and you can be part of that. And if we do not look through those lenses, we're just perpetuating the issue, and we are not taking care of people's health. So I just want to applaud you for being here and to tell you to continue this work, because this is important, just as important as being able to be medically trained and all of that too.
Thank you. And as somebody that's worked at several different healthcare institutions, do your homework before getting hired somewhere.
Yes.
Frontline staff will talk, ex-frontline staff from that location. They'll let you know if it's an environment where you may not be safe.
That is
and toxic. So it's very important to do your homework on that. I know there's a lot of questions,
She just wants to add.
Yeah, I just really want to say something to the students who have come. So thank you for being here. One quick thing that I would say to you. So first of all, there's so many different areas of healthcare that you can explore. So just really be open to exploring all of those different options. I don't know a good place to look, but I'm sure if you look at the different schools and institutions, you'll see all of the different healthcare programs that are available. So lots of options available. And then I guess the last thing I would say is just always think about how those social or structural determinants that I mentioned play into the care that you're providing. So it's not just about the medical side or as part of the medical side. You want to think about all of those other factors that influence people's health.
Yeah, and Laura, if I could just add one factor that we can also bring to healthcare is just an awareness of who you're dealing with. Because, and I know this has been mentioned at times, but I remember doing some care on an elderly lady. She's in bed, and as I lean over, she reaches over and grabs my hair and says, "Oh, I love your hair," because I had dreads at that time. And that's often a trigger for us, is when somebody pulls your hair and says, "Oh, I love your hair." But this was a lady who, she's in her 80s. She used to be a hairdresser in this small town where I worked. She was, bedridden with dementia, seldom said anything that made sense. So the fact that she touched my hair and it brought back a memory for her of doing hair, and she was able to make that sentence of, "I love your hair," I was totally touched by that. And so just to hook on to what you were saying about knowing things, knowing your people as well, I think can make a real difference to how you react to something that might, in a different situation, be triggering for you. For me, that was just a beautiful moment. I just wanted to share that because we all have hair issues.
That was a lovely story. Thank you, Bridget. Okay, so I want to thank our panelists, Claudine, Debbie, Michelle, for sharing your insights, your experiences, and your commitment to equity. And thank you to everyone here in the audience for listening, learning, and being willing to engage with this really important conversation. Hopefully, maybe in a little while, we'll be able to do something like this again. So let's think. Back in our workplaces, our communities, and our daily lives, because every action, every conversation, and every choice moves us closer to healthcare that is just, equitable, and inclusive for all. Thank you, and let's keep the conversation going. Thank you, guys.
Of the Anishinaabe, which include the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy. The local bands consist of the Chippewa Tri-Council, who are made up of Osané First Nation, Georgina Island First Nation, and Brandon First Nation. We would also like to acknowledge the Wendat Nation, Huron, who occupied these lands prior to the middle of the 17th century. We also recognize the enduring presence of all First Nations, Métis, and Inuit peoples. So welcome everyone. My name is Christina Mancuso, and I'm the Education Officer of Schools and Community Programs here at the McLaren. It is with pleasure to welcome you all to a very special Lunch and Learn event in acknowledgement of Black History Month. For over 4 years, the McLaren has maintained a strong partnership with Making Change, supporting and collaborating on the vital events and education programs that they create. We are honored to continue this partnership by hosting this important panel event called The Hidden Cost of Care, Racism, Inclusion in Healthcare Workplaces. We hope this discussion sparks meaningful reflection and sustained action across communities, and we're grateful to the distinguished speakers here with us today for helping us embrace our collective responsibility and foster change. Thank you to the staff and board of Making Change, as well as panelists Debbie Mulder, Dr. Claudine Cousins, and Dr. Michelle Quay, for being a part of this panel and sharing your knowledge and lived experience. Now I'd like to introduce LaChapelle, Program Director of Making Change, as she will introduce our esteemed panelists as well as moderate the panel.
Thank you, Christina. And thank you, everybody here. This is an amazing opportunity. We're so excited. It's been a couple of months in the making, and it's finally all come together. So thank you to everyone here for joining, for participating. And good afternoon on this gorgeous day. So my name is Laura LaChapelle, and I'm the Program Director for Making Change and your moderator for this event today. I'm a PSW of 20 years. Some of you may not know that, but that was my career before joining the nonprofit sector. And now I'm in this new programming advocacy role. And I sit at this intersection of frontline care and systems advocacy work. I've witnessed firsthand both the beauty of compassionate healthcare and the deep harm caused by systemic racism for patients, families, and healthcare workers. So today isn't about pointing fingers. It's about hearing the truth. It's about developing understanding and changing together. So I'm honored to introduce our 3 panelists. I'm going to introduce them here. They're 3 women with an incredible range of lived work and community experience. So first up, Dr. Claudine Cousins, CEO of Empower Simcoe. And next, I'm going to bring up Debbie Mulder, Manager of Equity, Diversity, Inclusion, and Belonging at Georgian College. Thank you. And last but certainly not least, the amazing Dr. Michelle Quay, Public Health Physician, Simcoe, Muskoka District Health Unit. What a powerful, powerful group of women. And it is an honor to serve with you 3 today here. Now, I look upon this panel event as groundbreaking. Nothing like this has ever happened in Simcoe County. And so I'm eager, as all the rest of you are here, to learn and listen to all 3 of you. So I'm going to ask a selection of questions that are important about this subject.